Ladies and gentlemen, welcome you all to this video intervention. Hope you are enjoying this session. And I can see more than 80 people are attending at the end of the second day. It's a great session. And hope you have enjoyed this intervention. It was an exciting one, definitely, as everybody was enjoying it. Now we'll go for the session with heart failure. It's a heart failure session. We have got 5 speakers. We have got Professor Mohammad Khaliqujaman with me as co-moderator. I am Dr. Mohammedullah Firoz, and we have got some eminent cardiologists in our chairpersons list: Professor M. Nazrul Islam, Professor Shajol Krishna Banerjee, Professor Abdullah Shafi Mujumdar, Dr. N.A.M. Mominuzzaman, Dr. Rafiq Ahmed, Professor Chaudhuri Hafizul Hasan, Professor Boren Chakraborty, Professor Chaudhuri Meshkat Ahmed, Professor Harisul Haq, and Professor Mirza Nazrul Islam. We have got a discussion panel, and Professor Prabir Kumar Das, Professor M. Shakil Ghafoor, Professor M. Mohsin Hossain, Professor Abdullahil Baki, Professor Liaquat Hossain Topon, Dr. M. Mukhlisur Rahman, Dr. M. Zulfikar Ali Lelin, and Dr. Muhammad Humayun Kabir are in the discussion panel. Ladies and gentlemen, we have got 5 speakers. They will talk on different aspects of heart failure. And after each speech, you can give us some comments and questions. And at the end of the session, we will also take some questions from you, and also from the comments from our chairpersons and discussants. Our first speaker is Dr. Jose Ramon Gonzalez Juanatey. Dr. Jose Ramon, are you with us? Dr. Jose Ramon Gonzalez. We have got our second speaker, Dr. Anil Saxena from India. Anil Saxena, sir, are you with us?
Yes, I'm here. Good afternoon, everybody.
Okay. We'll go with the second speech, and as long whenever our first speaker becomes available, I will go for his lecture.
Yeah, sure.
Sure. Dr. Anil Saxena is very popular in India and Bangladesh. We are known to, everybody knows him, and he doesn't need any description or introduction. Yet I am telling something about him. Dr. Anil Saxena is the Director of Cardiac Pacing and Electrophysiology in Fortis Escorts Heart Institute, New Delhi, India. He's working there for more than 30 years. Cardiac arrhythmia is the field of main interest, and he's a pioneer in CRT and ICD implantation in India. He's the Chief Editor, Associate Editor, and member of editorial board of a number of prestigious peer-reviewed journals. Dr. Anil Saxena will talk on heart failure with reduced ejection fraction, treatment optimization for CRT implanted patient, when and how. Dr. Anil Saxena, sir, it's your time.
Yeah, good afternoon, everybody. First of all, I must thank for giving this opportunity. It's truly an honor. It's a long topic, and I will try to be as concise as possible. My talk is on heart failure treatment optimization for a patient who has already been implanted a CRT device. So how should we look after these patients? Without going much into discussion about the CRT itself, just a couple of slides. We know that CRT is a very efficacious treatment for heart failure patients, particularly those who have wide QRS complex and a left bundle branch block morphology. And in these patients, we implant this device, which has basically 3 leads. One goes into right atrium, one in the right ventricle, and one we pass through one of the tributaries of the coronary sinus after identifying it on the venogram. So the important thing is that we must space the lateral wall. Just 3 important things about CRT. One is that we must space this free wall of the left ventricle. It could be anterolateral, lateral, or slightly posterolateral. Second important point is that there should be maximum interval between the 2 leads, that is the left LV lead tip and the RV lead tip, for maximum benefit. And third important thing is the electrical separation between the RV sense electrogram and the LV sense electrogram. It should be at least 90 to 100 milliseconds. If we ensure these, the likelihood of getting a good response is much better. But what we have seen is that despite whatever we do, the response can be quite variable. And some patients can be super responder, which may be about, you can say 15-20% patients, where the EF can almost normalize. A good number, 30-40% additional, would be responders. But then 30% patients feel that, doctor, I'm almost same as I was before. Some of them, we call them non-progressors, that is, they get stabilized. So their trajectory would have been downward, but they got stabilized. The patient would know that, and he may say that, oh, doctor, I'm almost like same. So, but they might have benefited. And then we have non-responders and we have negative responders as well. So some patients actually become worse, where the dysynchrony may sometimes increase. So coming to my talk, how can we get the maximum out of CRT, and how can we continue to manage our patients with heart failure as best as we can? So the first, I will divide my talk into these 5 headings. One is we must ensure that the patient is getting adequate CRT pacing percentage, because unlike pacemakers, where we want to minimize the pacing, in CRT we want to maximize pacing so that patient gets full benefit. Ideally 100% pacing should happen. Second, the performance of the device, threshold, output, sensitivity. Then we have to do device programming as far as the timings are concerned. And then we continue to optimize the drug therapy, and then we do the comorbidity and lifestyle management. So first step is to ensure that the patient is getting enough CRT. And there have been studies which say that at least 92 to 95% CRT delivery should happen where we can expect a good response. And in this particular study, they found that it should be greater than 92%. There are so many studies. In this particular study, they found 98% CRT delivery should be there to get a good response. So we can have a ballpark figure of 95% plus. That's what we expect and desire. And to do that, we must make sure that the patient doesn't have atrial arrhythmias. We must adequately shorten the AV delay. We must try to have as high upper tracking rate as possible. We can have a short PUR to achieve that upper tracking rate as high as we can. And there are many device algorithms like auto PUR, pen auto, AV delay, which can allow us maximum tracking, so that one-to-one tracking can happen up to 130, 140 heart rate, so that patient doesn't have loss of CRT delivery. Atrial fibrillation is a particularly common problem, because atrial fibrillation and heart failure, they often go together. And managing atrial fibrillation is very important, because if the patient has high ventricular rate, then the CRT will not be delivered. It has to be atrial synchronous ventricular pacing. So if the patient is in atrial fibrillation, often patient doesn't get therapy. And there are so many algorithms which enhance the delivery of therapy in atrial fibrillation. One of them is, like, for example, conducted AF response. Another one is ventricular sense response, where the device will sense the QRS complexes, and at the same point, it will deliver the biventricular pulse. So it will try to maximize the CRT delivery. And there are many other algorithms which I will not go into the details for the want of time, like atrial rate stabilization, atrial pacing preference. All these are designed to minimize the burden of atrial fibrillation in CRT patients, and therefore maximize the therapy delivery. But sometimes any of these things don't work, and we have to disconnect the AV node, and then one can obviously deliver 100% CRT. And as we can see in this particular example, after the AV node disconnection, we see that the pacing percentage is now 100%, and the patient's heart rate also gets stabilized. And there is enough data to suggest that these patients actually do quite well in the long run, as compared to if we don't disconnect the AV node. The response can be almost as good as patients with sinus rhythm. The second step is to do a conventional work. Every time the patient comes, we must check the sensitivity and adjust sensitivity, threshold, and output programming. We must look at the lower rate, upper rate, rate response as such. We must look at the battery, device, and all the typical pacemaker follow-up that we do to maximize the benefit to the patient and give the patient an individual prescription of CRT, because we want rate and rate response to behave in a certain manner in an individual patient. So we optimize that. And of course, we do capture management. Most pacemakers now have automatic capture management, so they can automatically check the thresholds and adjust the output. Another thing related to CRT is a anodal capture from the right ventricle. If we program LV tip to RV ring, then patient may get both the pulse, both the stimulation in the right ventricular apex, and patient then will have similar configuration of ECG from the RV pacing and LV pacing. So that is something we must identify and resolve. And as far as possible, we are trying to now select the device with the quadripolar leads, the LV lead, which has multiple pacing points. And we can look at which vector is giving the best response. So there are multiple vectors possible, up to 16 to 20 vectors possible in CRT patients. The pacing configuration from the left ventricular lead. And we should do any study, either echo guided, or there are automated algorithms which help us solve this problem of two problems. One is pacing threshold, and of course, phrenic nerve stimulation, because some of the patients with CRT, they have phrenic nerve stimulation, which also limits the delivery of the CRT. So this can help. And of course, the new devices have an algorithm called multi-point pacing, where we can pace on the left side from 2 electrodes instead of 1. That will increase the larger area of waveform, and it can further enhance the results of the CRT delivery. Next, we come to optimizing the timings and algorithms of the CRT. This is again a long topic, and if I have to very briefly mention, we must say that we must try to maximize the diastolic filling time, because that is where the ventricular filling takes place. We must minimize the aortic pre-ejection period to an optimum level, and we should try to minimize the mechanical dysynchrony, which was the basic problem for which we implanted the CRT. For that, we have to optimize the AV and VV timing. And in the optimization of AV timing, for example, we keep on reducing the AV delay till we find that there is a A wave is getting cut off, and that is the point where we go back 10 milliseconds, and we just try to minimize this pre-ejection interval to minimum, so that we have maximum efficiency of the left ventricular output. The VV optimization can be done. VV means between RV and LV stimulation. We can use either LVOT VTI, which is a surrogate for stroke volume. We can use dysynchrony as a criteria, or we can have QRS duration as a criteria. All are good. LVOT VTI is often preferred because it is actually direct surrogate of the cardiac output, stroke volume, which defines the cardiac output. And there are many automated algorithms in these devices. For example, the Senju device it had quick opt earlier, and which would measure the various timings, the atrium to ventricle sense timings, and ventricle pacing, LV pace to RV sense, RV pace to LV sense. And it comes with a set of desirable parameters, which have been shown in studies to match the echo guided parameters. So this is something that we often do. And now we also have another algorithm called from Senju Abbott, that is, it's called Sync AV CRT, which does it very on a dynamic basis, on beat to beat. Every 256 beats, it will calculate these intervals and come up with the pacing parameters and automatically adjust. Medtronic have a similar algorithm called adaptive CRT, which also measures the intrinsic timings, conduction timings, and comes up with a set of parameters which can automatically optimize the AV and VV delay. So these algorithms can be of some help in some patients, but by and large, the device optimization has not shown to be very beneficial. There are no set guidelines, and most of the studies, they have shown equivocal results, and mainly because the echo guided parameters are not very reproducible from lab to lab. So that's the problem. The next important thing is optimizing GDMT, that is guideline directed medical therapy. Now, it's often seen that the patients, once they get the device, they often don't take their medicines properly. The compliance gets reduced. They feel that now they have the device, so they should not worry about their food intake, fluid liquid intake, salt intake, and of course medicines also. But that is not true. We must make sure that we emphasize again and again that we must continue the medical therapy, as well as the diet restrictions. And one important thing here I would like to mention is that in many patients after CRT, we are able to scale up the medicines. Instead of reducing them, we can scale up, because many patients who don't tolerate enough doses of beta blockers or ARNI or some other medicines because of hypotension or bradycardia, after CRT, we are able to scale up the medication, and they actually then benefit even more. So this is something to be emphasized to the patient, that the device can actually allow us to, on one hand, it can reduce the loop diuretics, but on the other hand, it can give us opportunity to increase the guideline directed therapy for modification of the disease process, that is like by the ARNI or beta blockers or MRAs, etc. So that is something which needs to be emphasized, and we must continue that aspect. And lastly, I would say that we must take care of the lifestyle and comorbidities. We must ensure good education to the patient and family about the heart failure, about the need to continue compliance, salt and fluid management, and we must recognize and treat precipitating factors like anemia, azotemia, arrhythmias, etc. We must look at other underlying cardiac diseases which are contributing to heart failure, for example, myocardial ischemia or valvular lesions, and sometimes some other cardiac disease. We must make sure patient adheres to the lifestyle changes and optimizes the body weight and continues exercise program. And of course, in many patients, we have psychological issues which sometimes don't allow us to quantify the benefit. Patient continues to say that he or she is not feeling well, which may be because of endogenous depression or some other psychological issues we must address. So I think it's a been very brief, but I'll be happy to answer if there's any question. Thank you very much.
We can take some quick questions and comments from the discussion panel and the chairpersons. If you have got any question or any comments regarding the lecture of Dr. Anil Saxena.
So please, may I give a question to Dr. Anil Saxena? What are the pre-implantation parameters, either ECG, echo, or MRI, that can predict the responsiveness to CRT therapy? Can you give some highlight upon that?
Yes, I think that's a very important question, because one important thing is that presence of a scar in the ventricle indicates that the patient has chances of poor response. So if you start with the ECG, a patient having typical left bundle branch block pattern should get better response as compared to intraventricular conduction defect, which is not like typical IVCD. And a lot of fragmentation in the QRS indicates presence of larger amount of scar. And wider the QRS, better the response. So more than 150 is definitely better than more than 130. So patients who have very wide QRS, they get better response. On the echocardiography, 35% is the cutoff, but lower the ejection fraction, patients are expected to get better response. Thirdly, we can do MRI to look at the quantum of scar. Not only quantum of scar, but also the location of scar, so that we can avoid those areas while placing the LV lead, because we can't make the scar contract. So that is something which can be done. We can also look at the imaging, and I try to identify, there was a trial called Target trial where they tried to identify the latest activation and contracting area of the left ventricle on echo, and try to give a LV lead in concordant placement. That was very effective. So these are the things that we can see. And of course, female patients, they respond better. Patients who have relatively normal LSI, they respond better. Patients who are not in atrial fibrillation, they respond better. So these are some of the criteria that we follow in guiding our patients.
I have one question.
Hello. I have a question. May I ask a question?
Hello.
Please.
Hello. Yes.
Okay, Professor Prof.
First of all, thanks to Professor Dr. Anil Saxena for his brief but very informative and brilliant presentation. We had the opportunity to be present in some sessions physically in Bangladesh.
Thank you so much.
So, as you mentioned, atrial fibrillation is a common concomitant in patients with heart failure. Do you suggest implantation of CRT in any patients having atrial fibrillation after doing AV ablation? What is your comment?
Yeah, so we recommend, because what happens is that we give a lower guidance to the patient. So instead of 70% possibility of benefit, we say, okay, you may have 50% possibility of benefit. But patients usually have no choice, no other thing to look forward to. So they agree to a CRT, and many of them do respond, about 50-60%. Now we try to lower the rate, ventricular rate in atrial fibrillation, so that we can deliver the therapy more effectively. So the percentage of pacing has to be as high as possible. And for that, we use the algorithms like the conducted AF response or ventricular sense response. And if we are not able to deliver therapy adequately and the patient's rate continues to be high and we cannot lower it by medical therapy, then we have to disconnect the that is very rare. We may have done maybe 2 or 3 patients in last so many years. So it's very rare, but that is something which is recommended, that we can disconnect AV node and then we can achieve 100% CRT delivery.
Thank you.
Thank you.
So I have one question, sir.
Yes, sir. We are running out of time.
Yeah, just regarding synchronization with defibrillation in CRTD and CRTP only. So many patients, we see that coronaries are normal. Younger patient, there is no obvious scar on echocardiogram. CMR is a good option, but we don't have any facility to do the cardiac MRI here. So there is no evidence of arrhythmia as well by 24 hours Holter or any other evidence of arrhythmia. So do we prefer the CRTD or without defibrillation?
See, in these patients, non-ischemic cardiomyopathy without much scar in the ventricle, the results of CRTP and CRTD are almost equal. And the addition of defibrillator hardly adds to the benefit, particularly because the benefit of ICD in non-ischemic cardiomyopathy was very small to start with. And with the modern medication, the outcome of these patients has improved so much that ICD will really struggle to show the benefit if we do these trials today. In absolute terms, there was hardly maybe 1% benefit, and now it may be reduced to 0.3 or 0.4%. So we can consider, we should do CRTP more often in those patients.
Thank you.
It's so much cheaper.
Thank you, sir. Khalagjan Bhai, our next speaker.
Thank you, Dr. Saxena.
Thank you so
much. Professor Atahar, next speaker. I request Dr. Saxena to comment on LV endocardial pacing versus LV epicardial pacing. Do you have any comment?
Is there a question to me?
Yes.
Yes.
Yeah.
LV endocardial pacing versus LV epicardial pacing. Which you prefer? And
So most of the like conventional CRT is LV epicardial only, because the coronary veins are epicardial. But endocardial LV pacing is also possible now, and in some cases which are not non-responders, it is possible to do. But the problem is of anticoagulation. We have to then give long-term anticoagulation. That is the problem.
Yes.
But yes, it is possible. Thank you.
Thank you very much. Thank you very much, Dr. Saxena, for your brilliant presentation and informative lecture, which have delighted us so much.
Thank you so
Now,
much.
let us move to next speaker, Professor Atahar Ali. Professor Atahar Ali definitely did the introduction in Bangladesh because
Khalikuজ্জামান, can I draw your attention, Dr. Khalikuজ্জামান, sir?
Yes.
Sir, Ramon Gonzalez in the screen. I think he came from his cath lab. So if you can, you just call him first, then Atahar Ali sir will give his talk, right?
Okay, Dr. Firoz, can you give some introductory speech about the Dr. Gonzalez?
Thank you, Dr. Professor Azam. Our first speaker was Dr. Jose Ramon Gonzalez Juanatey. He is from Spain. He will talk on heart failure, unmet challenges, and emerging therapies. Dr. Jose Ramon Gonzalez is the past president of Spanish Society of Cardiology. He is the director of cardiovascular department, University Hospital, Santiago de Compostela, and professor of cardiology, University of Santiago de Compostela, School of Medicine. He is the member of ESC Education Committee and member of number of task forces for a number of ESC guidelines. He is the member of editorial board of European Heart Journal, Lancet, Circulation, American Heart Journal, Revista Española, D. Cardiologia. His topics of interest is heart failure with preserved ejection fraction, hypertension, acute coronary syndrome, and cardiac myocyte endocrinology. He has got more than 500 publications in the most prestigious journals in the world in the field of cardiovascular medicine. Dr. Jose Ramon Gonzalez, please.
Thank you. Thanks for the introduction, and thanks for the invitation to participate in this international summit. My topic is heart failure, and as probably you know, last weekend was presented in advance antevision of the new ESC guidelines that will be published in the full paper and presented in the next ESC Congress at the end of the next August. I will address the issue of the emerging therapies, some of the new aspects that probably could be included in the new ESC guidelines. On this slide, my disclosures. And first, I would like to address the diagnostic challenges in heart failure. And recently was published the first universal consensus, the universal definition of heart failure. This is a joint paper for the ESC, the American Heart, the American College of Cardiology, and the Japanese Cardiac Society. And this is the new classification proposed, and is the new classification that is included in the next ESC guidelines. Heart failure will reduce ejection fraction, defined by an ejection fraction lower than 40%. The new category, that is the new definition of the new, in the past, in the previous guidelines, we define as mid-range, and now is defined as mildly reduced ejection fraction, an ejection fraction between 41 and 49, preserved ejection fraction higher than 50 and equal than 50, and a new category that is, for me, very, very important, this new category that is included in the classification of heart failure, that is heart failure with improved ejection fraction. And here in the slide, you can see the definition of the improved ejection fraction in patients with depressed that increase the ejection fraction. And this is so important because in the new ESC guidelines, ejection fraction will be considered as a therapeutic target because the patients with an improvement in ejection fraction, the prognostic is much better than patients who remain with depressed ejection fraction. So the aim in the clinical practice in patients with depressed ejection fraction is increase the ejection fraction by means of the background therapy, the prognostic implications, the therapy with prognostic implications, revascularization, cardiac resynchronization of all the interventions that it may increase the ejection fraction in heart failure. So this is the proposal that HFrEF, if the patient improves the heart failure, is like in cancer, it's like a remission of the heart failure syndrome. The patient needs to maintain the treatment, but the prognostic improves a lot. The prognostic is much better in the patients with deep remission, with this improvement in ejection fraction and the reduction in the cardiac volumes. This is one of the news that should be included in the new ESC guidelines, ejection fraction as a therapeutic target. And HFpEF, this is the proposed algorithm for the HFpEF diagnosis. In clinical practice, HFpEF is a clinical syndrome of heart failure, and then the use of natriuretic peptides, echocardiography and echo and Doppler and the E prime cutoff points. So this is the proposed clinical algorithm for the diagnosis of HFpEF. I think this is critically, we have to get in considerations the clinical elements that should be included when you establish the diagnosis of HFpEF. It's a clinical score system that was previously published and position paper of the ESC, and this is the algorithm that should be included in the next ESC guidelines. And what about the therapeutic challenges? In the ESC guidelines, it is what is new in medical treatment in ESC heart failure guidelines, a new algorithm, the new recommendations for mildly reduced in the past mid-range and now mildly reduced, a new classification, characterization of patients with heart failure based on ECG, the etiologies, and other clinical parameters. So what is new in the ESC? And this is the new algorithm, treatment algorithm for the management of heart failure with reduced ejection fraction. This is an algorithm with four class of drugs with a demonstrated improved mortality risk and a demonstrated improvement in the reduction in the need of heart failure hospitalization. ACE inhibitors or ARNI, sacubitril valsartan, as class 1, but the guidelines probably will say that ARNI is preferred, but include also ACE inhibitor as a possibility. And in patients with previously treated with ACE on RRB, then ARNI should be included, should substitute ACE or RRB, beta blockers, anti-ALDO, and SGLT2 inhibitors. This is the four groups of drugs that should be included unless contraindicated or unless not tolerated by the patients. Diuretics only in patients with volume overload, only in the presence of congestion, not for all the patients, only in this clinical situation. RRBs should be used only in cases of patients with intolerance to ACE or ARNI. Carboxymaltose intravenous iron in patients with iron deficiency. This is 2A. Digoxin was increased the level of evidence. This is 2A in patients with that needs digoxin for rate control in patients with atrial fibrillation, ivabradine and hydralazine and dinitrated isosorbide. But the four bigs, the four class of the patients. And it's the table. ACE is recommended for patients with HFrEF, that you see is a class 1 level of evidence A. Then sacubitril valsartan is recommended as a replacement for ACE in patients with HFrEF with the aim of reducing the HFrEF or heart failure hospitalization and death. So sacubitril valsartan may be the first option in patients with HFrEF, or substitute ACE inhibitors in patients with stable HFrEF in the ambulatory basis. The issue is the evidence that we get support that ARNI should be included as first line instead of ACE inhibitors of RRB. We have a clinical trial, that is the Pioneer HF, and in naive patients, in patients without a previous treatment with ACE on RRBs, that is half of the patients included in Pioneer, the reduction in NT-proBNP compared with enalapril was significantly higher, and the events was significantly less. But the trial was not designed to test the hard endpoint. So with this evidence is sufficient to delete ACE inhibitors from the first line of treatment in patients with heart failure. Probably all of you will have your position, but I think that is not a relevant issue. ARNI is significantly better than ACE inhibitor, but if you start for many reasons, maybe for economic reasons due to the price of sacubitril valsartan, but in the case that you start with ACE, then you have to consider the change of ARNI in such patients. And one of the new is the inclusion as class 1 level of evidence A of the SGLT2 inhibitors, particularly dapagliflozin and empagliflozin, based on the HFrEF clinical trial in diabetic and non-diabetic patients with HFrEF. Dapagliflozin much improved the prognostic of the patient, reduced the risk of the composite endpoint of cardiovascular death or worsening heart failure, and the same findings in EMPEROR reduced. Empagliflozin reduce the risk of suffering the components of the primary endpoint, that is worsening heart failure and cardiovascular mortality. These are the two big trials in HFrEF this is the reason why the new ESC guidelines and the American guidelines, the Canadian guidelines include SGLT2 inhibitors as class 1 level of evidence A in all the patients with HFrEF, irrespective to the diabetic conditions. And at the end, in HFrEF, you have to include ACE, ARNI, probably preferred ARNI, beta blocker, anti-ALDO, and SGLT2 inhibitor. The mechanism of the FARF drugs are independent and additive, and the benefits regarding the improving the prognostic are incremental. So the goal is include all the 4 drugs, the earlier the better, with this aim. And probably, and this is one of the recommendations of the ESC guidelines, you have to discharge the patient from the hospital with all the 4 drugs, and then up-titrate the dose. But some of all of the 4 drugs, unless not tolerated by the patient. This is the American algorithm. Here is stated that ARNI is preferred, and then beta blockers, and then SGLT2 inhibitors of anti-aldosterone antagonists and aldosterone antagonists, considering the kidney function and the potassium, and in this case also the kidney function. Is more or less the same algorithm. This is the Canadian algorithm that is almost the same algorithm that the new European algorithm, and you see that is ARNI or ACE or RRB, and then substitute by ARNI. Is the same philosophy that the ESC guidelines or the ESC new algorithm, beta blocker, anti-ALDO, and SGLT2 inhibitor. And this is the 2 years mortality with none of the 4 drugs. The 2 years mortality is higher than 30%, and with the optimized medical treatment in patients with HFrEF, the annual mortality is less than 5%. This is really it's an impressive improvement in the prognostic, and this is the reason why you have to try to include the 4 drugs in the treatment algorithm of your HFrEF patients, because the prognostic impact and the improvement in the quality of life is much significant. But at the end, you have to consider several clinical issues: the heart rate level, the blood pressure, atrial fibrillation and non-atrial fibrillation, chronic kidney disease, because you have to individualize. And this is much important in heart failure. You have the need for individualized the treatment. For example, in the future will be included in the armamentarium of heart failure. We reduce ejection fraction vericiguat based on the Victoria trial results, that vericiguat improved the prognostic in heart failure in patients with advanced heart failure, patients with repeated readmissions to the hospital. What about the role of the priority patients for the use of vericiguat? Here, the iron intravenous iron, in this case, the affirm acute heart failure in patients with iron deficiency, an improvement particularly seen in reducing the risk of hospitalizations, non in the reduction of cardiovascular death. This is the reason why in the new ESC algorithm, this is a class 2A recommendation, and you have to identify patients in clinical practice with heart failure and iron deficiency. And again, a sub-analysis of the Cabana trial, the role of cardiac ablation in atrial fibrillation, vein pulmonary ablation, and this is the improvement in the prognostic in the subgroup analysis. This is a subgroup analysis with all the limitations and improvement in the prognostic based on the atrial fibrillation ablation in patients with heart failure. So you have to select heart failure patients with recent atrial fibrillation for considering ablation. And a new chapter is patients with heart failure and cancer. You have to develop areas of cardio-oncology in the hospitals. You have to identify the cardiotoxicity, particularly in women with breast cancer, because you use, in this case, ACE inhibitors and beta blocker for the reduction, the risk of cardiotoxicity, and particularly the reduction, the risk of suffering chronic heart failure. So it's needed to develop in clinical practice areas of cardio-oncology for optimize the risk, cardiac risk in oncology patients. This is the results of our paper recently published in the European Heart Journal. You have to identify and treat early the possible cardiotoxicity because the patients, particularly women with breast cancer with cardiotoxicity, the prognostic is worse regarding the other group of patients. You have to identify the cardiotoxicity and treat the patient with the aim of avoiding the development of overt and chronic heart failure. And at the end, HFrEF, in this case, HF failure with mildly reduced ejection fraction and HFrEF. This is the table. This is a crazy table in my point of view, because all the drugs is 2B and level of evidence C. This is saying nothing, almost nothing in heart failure with mildly reduced, heart failure with an ejection fraction. And 49, you have to individualize the treatment based on the phenotypic, on the clinical characteristic of the patients. This, from my perspective, this is a crazy table. Does not add nothing relevant from a clinical point of view. The possible role of sacubitril/valsartan in patients with an ejection fraction lower than 57, 55. This is many patients in the mildly reduced ejection fraction based on the Paragon sub-analysis, and this is the reason why it was accepted as a possible indication by the FDA. And recently was published a press release regarding the results of the Emperor Preserve. Emperor Preserve is a clinical trial in heart failure patients with an ejection fraction higher than 40, so includes patients with heart failure with mildly reduced and preserved ejection fraction. The press release said that the empagliflozin improved the prognostic of these patients for the first time, a clinical trial improving the prognostic, but we have to wait to see the full paper in New England Journal of Medicine and at the end of August, and also will be presented in the ESC. This is probably a new era in HFpEF, in HF failure with mildly reduced, but we preserve ejection fraction, but we have to wait. And we send, because I am in the steering committee of the trial, we sent the paper for considering for publication in New England this week. And at the end, the patient care pathway, this is critical. this is the new recommendation of DSE guidelines. The patients should be discharged from the hospital with some of the 4 drugs improving the prognostic: ACE, ARNI, ACE of ARNI, beta blockers, anti-ALDO, and SGLT2. And then the patient should be followed a health contact in 1-2 weeks after hospital discharge. For me, this patient care pathway organization is critical in the organization of patients with heart failure. And then this is the patient pathway during the hospital stay. And then this is in the transition to oral therapies. At the beginning, due to the congestion, low cardiac output, the patient needs many patients intravenous medication. And in the transition to oral therapies, these big 4, with this objective, the earlier the better, and discharge the patient from the hospital with some of the 4 drugs. You have to take into consideration that the tolerance of the neurohumoral blockade, the RAS inhibition, the renal function, the potassium, the hypotension. And during the hospital stay, because the patient is well controlled, probably you can start with beta blocker and ARNI, and then include anti-ALDO and SGLT2 inhibitor. This could be maybe a strategy. SGLT2 inhibitor is one dose, one step, but the other drugs is 1 of 2 doses and several steps for achieving the target dose. And recently it was published that if the patient with heart failure is already treated with an SGLT2 inhibitor, in this case empagliflozin, the risk of suffering side effects under anti-aldosterone with aldosterone inhibitors, antagonists, is much less. So this is the reason why Milton Packer and John Murray propose that you can start with beta blocker and SGLT2 inhibitor, and then include an ARNI, an anti-ALDO, probably due to the beta tolerance of ARNI and anti-ALDO, less risk of suffering, particularly hyperkalemia. Otherwise, you have to design an individualized strategy in your patients with HFrEF. Not all the patients with HFrEF are made equally, so you have to adjust your strategy, but the aim is to include all the 4 drugs in the treatment strategy after hospital discharge, and then plan the follow-up for increasing the dose. And this is my final slide. This is the ESC guidelines probably, and we can discuss, include recommendations for device therapies, ICD, CRT, mitral clip, revascularization after the ischemia trial, and the results in the ischemia trial in patients with cardiac dysfunction, the diagnostic and the treatment in acute heart failure, the role of amyloidosis, and the COVID-19, and the role of COVID-19 in suffering heart failure and in patients with previously heart failure. So this is my view of the emerging therapies and my view of the news, what's new in the new ESC heart failure guidelines. Thank you. And then if you have any comment of any questions, I will be more than happy to comment. Thanks. Hello? I can hear you.
Please unmute yourself.
Yeah.
Okay, thank you. Thank you, Jose Ramon, for your brilliant presentation. It is really an updated presentation on heart failure. We can take very few questions. I think there are a lot of questions. Among the chairpersons and discussant, have you got any comments and questions? I can see Shazal Banerjee, sir.
Yes.
Sir, have you got any question or comments?
This is an exceptional presentation by Gonzalez. I must congratulate him. And I also congratulate Dr. Anil Saxena for his nice presentation. I have a question to Gonzalez. Is there any recommendation of any drug to prevent heart failure right now? Is there any preventive drug?
Yeah, it depends of the type of patients. For example, in patients with ischemic heart disease, in patients with normal left ventricular ejection fraction, probably ACE inhibitors prevent heart failure. So probably beta blockers, the combination of beta blockers and particularly ACE inhibitors prevent heart failure in ischemic patients. In diabetic patients with normal ejection fraction and without heart failure, SGLT2 clearly prevent heart failure. So in our ischemic patients, SGLT2 inhibitors, particularly ischemic patients with diabetes, the SGLT2 inhibitors prevent heart failure. Recently was published a subgroup analysis in the ischemia trial that patients without the clinical syndrome of heart failure, but with depressed ejection fraction, an ejection fraction between 40 and 50%, the revascularization in the case of suitable anatomy reduce the risk of suffering heart failure. So at the end, you have to consider the type of patient. For example, in hypertensive patients, the blood pressure control much reduce the risk of suffering heart failure. But I think that the newest evidence suggests that the blockade of the RAS system in ischemic patients prevent heart failure, and SGLT2 inhibitors in diabetic patients prevent heart failure.
Thank you, sir.
Thank you. Very recently, there is a report that SGLT2 inhibitor is a preventive drug irrespective of risk factor. Do you agree?
But SGLT2 inhibitor is a preventing drug in the cardiorenal syndrome. Not only protect the heart, prevent the heart failure development, but also prevent the kidney dysfunction. At the end, is a kind of blockade of the cardiorenal syndrome. But this demonstration only was seen in diabetic patients. In non-diabetic patients, based on the result of the DAPA-CKD, was seen in patients with chronic kidney dysfunction, irrespective to the diabetic or non-diabetic. In this case, patients with chronic kidney dysfunction, dapagliflozin in DAPA-CKD prevent the cardiovascular complications and prevent also heart failure. But SGLT2 inhibitors mainly prevent heart failure in diabetic patients, and now after the DAPA-CKD, also in non-diabetic patients with chronic kidney disease.
Thank you, sir. Thank you. Dr. Jose Ramon, do you recommend continuing all these 4 drugs in patients with heart failure with recovered ejection fraction?
That is a very interesting question. But as I mentioned before, the new heart failure classification includes this new category of recovering heart failure, improving in left ventricular ejection fraction. This is critical because this subgroup of patients with an improvement in ejection fraction, the prognostic is much better. But you have to, the recommendation is continuing the same medication. Probably because this is like in the cancer, this is the remission of the heart failure syndrome, but at the end, the cardiovascular and the cardiac damage remain. And 2 years ago, I think was published in Lancet that in patients with heart failure syndrome, reduced ejection fraction with an improvement in ejection fraction. If you delete the drugs, the patient again develop the heart failure syndrome and depressed ejection fraction. So unless the improvement in the cardiac remodeling process and the improvement in ejection fraction, you have to maintain the 4 drugs.
Thank you, sir. I think we can move on to our next lecture.
I had a little comment. As your continuation of all drugs, since the pathophysiological mechanism which involves in the heart failure is well counterbalanced by all these 4 pathways, and the pathophysiology is ongoing. So it is quite rational to continue all these 4 drugs. And it is so fortunate for the patient with heart failure that the drugs which act on angiotensin pathway, the beta blocker pathway, the neprilysin pathway, and the AGL2, these all 4 pathways do not interact with one with another. And that is why the ESC has been so smart in giving the recommendation about all these 4 drugs. So it will be wise to continue all these drugs during the recovery phase. Thank you very much.
Thank you.
May I have a short question to Gonzalez?
Dr. Nuralam, please.
Dr. Gonzalez, just I want to draw your attention. Please have a comment regarding 2 diuretics. One is tolvaptan and another is metoprolol. Usually we use tolvaptan in hyponatremic patient, especially in SIAD, syndrome of inappropriate ADS hormone, and metolazone. Have you any experience regarding these 2 drug metolazone and tolvaptan in heart failure patients as a diuretics?
No much experience, but I have some experience in our center with tolvaptan in patients with hyponatremia, for example, for improve the diuretic profile of such patients. Probably the highest experience is with tolvaptan for increasing the diuretic effect, particularly in patients with hyponatremia. This is the recommendation for using tolvaptan added to other diuretics, particularly loop diuretics.
Thank you, Dr. Ramon
Thank you.
Gonzalez. We are running very short of time. We are sorry that we cannot take any other questions about the topic. There is brilliant presentation by Dr. Gonzalez on unmet challenges. Although we have many unanswered questions, but we have to move to next speaker due to our time constraint. Our next speaker is Professor Atahar Ali. I think he does not need any introduction in Bangladesh. He's a brilliant cardiologist, a clinical cardiologist, an interventional cardiologist, and then electrophysiologist. He started his journey as a cardiologist in National Institute of Cardiovascular Diseases, and he's considered to be the pioneer of electrophysiology in Bangladesh, and he set up an electrocardiology department in National Institute of Cardiovascular Diseases in Bangladesh. He was guided by Dr. Rafiq Ahmed from USA. He retired recently and he joined in Evercare Hospital, where he established an electrophysiology department and the department of the heart failure. He did a lot of device implantation in NICBD, and he knows every constant corner of the electrophysiology in Bangladesh, beginning from the very start of the journey till now. May I request Professor Atahar Ali to deliver his speech. Please,
thank you,
Professor Atahar Ali.
Yes, thank you, Dr. Khalik Azam, for nice introduction, and thanks, Dr. Firoz Ahmed, also for Mahmudullah Firoz for being with us, and Honorable Chairperson, respectable panelist, and dear participants. Good afternoon. And Dr. Khalik Azam, may I share my screen?
Sir, yes, sir. Please. You can start and continue.
So can you see my slide?
Yes, sir. Good. Nicely seen and nicely heard. You can continue.
Okay, thank you very much, and thanks, organizer, for giving me the opportunity to talk in such big forum. My my speaking engagement is in this meeting is sponsored by the Novartis Bangladesh Limited. This is the financial disclosure. And my talk is heart failure management from drugs to device in Bangladesh. That is focus is Bangladesh. So, dear Honorable Chairperson, Bangladesh is a small country, but it hosts more than 2% of the world population, and it stands 8th in population number in the world. So this is the Bangladesh. And before going to the main talk, I give some ideas about the heart failure status in Bangladesh. But unfortunately, we don't have our own data. And just for assumption, I can just projected the data from the US data as because the US population is 332 million and Bangladeshi population is 160 million, just half. So the US data is standard. There is no own data, our prevalence, incidence, and regarding the mortality. So on these 3 points, I have extrapolated the data from the US data. As for example, the prevalence of heart failure in United States is 6.5 million. And that should be nearly 3 million in Bangladesh, as can be projected from this data. And the incidence is nearly 1 lakh in United States. And that should be nearly 50,000 in Bangladesh. That is in each year, 50,000 heart failure patients are being added to the ongoing pool. And the last mortality, this is universal, the global findings, that is nearly 50% of the patients die within 5 years of diagnosis. So from this point, we can expect what is the burden of heart failure in Bangladesh. And this is the timeline of the heart failure management. And you will be surprised to see there was only diuretics and digitalis for the treatment of heart failure just 40 years ago. The dramatic changes and improvement has occurred since 1980s. And for the new innovation or addition of the new, that is the documented drug, that is the drug for the proven benefit, it took about 1 year, 1 decade. As for example, in the decades of the 90s, just vasodilators comes in place. In the 90s, angiotensin convertase enzyme inhibitors. And in the 2000, the revolution came when the ICD and CRT was started to use in the treatment of the heart failure. And 2010s onwards, ARNI, SG12 just discussed. So this is the timeline. We can see what is the actually dramatic changes that have seen the heart failure management over the just 40 years. It was very previous, even just 40 years ago in the 1980s. And there are some of the newer drugs. These are the pipeline. This is the nesritide, urodilantine. These are some of the drugs. These are under the trial. Hopefully they will be proved there, either they will be used or not used. Or these are not still not recommended for the use for the heart failure, but these are under the trial in the different small studies. So this is the timeline for the heart failure management. And this is already discussed by the Gonzalez, that is the beta blocker, AC inhibitor, and aldosterone antagonist. These 3 are the main pool that form the triple therapy. This is very effective for the treatment of the heart failure. And these 3 drugs can reduce the mortality compared to the placebo. As for example, the AC inhibitor 16%, beta blocker 30%, 34%, aldosterone antagonist 30%, and the receptor blocker 70%. And most important information is that the benefits are additive. That is, when the triple therapy is given, there will be additions of the benefits. That is, the each of the drug contribute their own benefits, and the total cumulative benefit will be the additive. So this is the very dramatic response for the heart failure treatment, and this is the reason why the triple therapy is very much useful, and that is popular. That is also practiced in Bangladesh. That is the triple therapy, but this is not the end. Despite the triple therapy, still there is mortality. There is the increased number of the mortality, and the introduction of the ARNI and SGLT2 inhibitors, just already discussed about their benefits and recommendation, the guideline. These 2 drugs also added some benefits to the total benefits previously stated. As for example, the total mortality benefit is 74% and absolute mortality reduction is 26%. So these are the 2 drugs, and all these 4 drugs makes the quadruple therapy. So previously it was the triple therapy. Now it is the quadruple therapy, just already discussed by the Gonzalez. And this is already practiced also in Bangladesh. So this is the additional mortality benefit. And from this slide, you can see the addition of the newer and newer drug or the devices is just addition of the life to the patient. As for example, you can see the bar length of the bar on the left side, that is the beta blocker. When the angiotensin convertase enzyme inhibitors are added, the bar is increased in the length, that is the further mortality benefit. When it is when this treatment is added with the ICD, again further mortality benefit. When the ICD with the anticoagulation for the atrial fibrillation, further mortality benefit. And finally, when CRT is one of the modal treatment, and it also increases the further mortality benefit. So addition of the treatment, not only the single treatment is unique for the patient, it is the addition of the treatment, addition of the drug, that is the triple therapy, quadruple therapy. And when still the patient is the risk, the quadruple therapy is added with some devices. So finally, it is the drugs and devices that forms the main platform for the treatment of the heart failure that is also practiced in Bangladesh. This is the drugs and devices. Neither the drugs nor the device alone are suitable for the treatment of the heart failure, for the mortality benefit, for the quality of the improvement of the quality of the life. It is the combination of the drugs and device that produce the platform for the treatment of the heart failure. As because drugs and device, both effects are additive, benefits of additive. So this is the drugs and device that forms the triple. So Bangladesh has entered into the arena of the heart failure device management in the year of 2008 and in electrophysiology in 2004. And the man in the screen, Dr. Rafiq Ahmed, we always feel honored to remember this person as because he has got the great contribution, pioneering role for the development of the electrophysiology and the device therapy in Bangladesh. So we must always salute this person, Dr. Rafiq Ahmed. And these are the devices that are currently practiced in Bangladesh. That is, we are routinely using. That is ICD, CRT, and newly the His bundle pacing. But we need to develop Impella, ECMO, LVAD. These are not being practiced in Bangladesh. Still, we have to develop these fields. But we have already developed this field. That is, we are already good some expertise and facilities for the implementation of the ICD, CRT, and His bundle pacing. But these things we have to develop further, as because these are the things, these are the treatment modalities which are essential for the bridge to the recovery, bridge to the transplant, or ultimately the destination therapy, and ultimately with the goal of the heart transplant. These are the essential in between this treatment and the heart transplant therapy. So these are the fields we have to develop further. And this is the one of the example of the CRT therapy. This therapy is routinely practiced in Bangladesh. Particularly, we use the class 1 or class 2A criteria. All the devices in Bangladesh, possibly we follow most of the cases. That is the class 1 or the class 2A criteria for the implantation of the resynchronization therapy. And this is the one of the example where the beautiful development of the ECG happened after the implantation of the CRT therapy. And this is the class 1 criteria, that is the sinus rhythm, LV mufflers, and QRS duration more than 150. And all the cases, that is the guideline directed medical management has been proved failed, and ejection fraction is 35%. So this is the class 1 criteria, and this is the class 2A criteria. So these are the cases, these are the conditions, these are the situations that is practiced in Bangladesh. That is the CRT therapy, that is the implantation of the CRT in Bangladesh. And this is the ICD therapy. This is also practiced in Bangladesh since 2008. And all the cases, we also here follow the class 1 or class 2A criteria. As for example, in cases of the post-MI cases, 40 days post-MI and ejection fraction less than 30 or 30%, or in case of the non-ischemic cardiomyopathy, the same ejection fraction, but the patient is more symptomatic. But we add the following criteria for the selection of the patient with this criteria. We do not use this criteria alone. With this criteria, we try to combine either of these. That is, the patient either has got the syncope, or the patient has got the documented VT, or that is the PVC. So either of this criteria in combination with this criteria, we follow for the selection of the patient for the ICD therapies. This is also developed, that is used in Bangladesh. And finally, recently, this has been introduced in Bangladesh, also in this subcontinent. This is one of the challenging therapy and possibly encouraging therapy for the heart failure patient. That is the His bundle pacing, or the pacing of the conduction system. In this case, this is very much rewarding and encouraging especially for the Bangladesh, is because it is less costly, but disadvantage is that it takes the long learning curve. Cost is less than the conventional CRT, but it takes the long learning curve. But if the financial thing is considered, this should be one of the good suitable option for the Bangladeshi patient. And these are the, again, some hopes that when the classic CRT is not fits the criteria, these are the cases that is the non-LBB, that is the class 2B criteria, non-LBB or RBB, or where the CRT are non-responders. This can be the one of the suitable responders. That is the conventional his bundle pacing or conduction system pacing may be indicated in this situation, or in situation where there is classic indications for the CRT therapy. So this can be one of the good option for the Bangladeshi patient, particularly because of that is the longevity of these devices are longer and the cost is less. So this is also practiced in Bangladesh, and it has been started in the last year. So this is one of the good option. But one of the important thing is that if we see this slide, that is from the 2016 to 2020, you see the number of the CRT implantation around 50. There is no dramatic changes in the number since over the periods of the 5 years. Also, the numbers of figures are also similar in case of the ICD. That is the implantation rate of ICD and CRT almost static over the last 5 years. The numbers are collected from the industry sales report. There is no published data. And these numbers are collected from the industry sales report. More important is that if we convert this figure in per million basis, it is the CRT implantation rate in Bangladesh is less than 1. That is nearly 0.35 per million of population. And ICD implantation rate is 0.43 per million of population. And if we compare this figure, you can see the annual implantation rate in USA is nearly 500. In India is nearly 8, but in Bangladesh, it is less than 1, that is a 0.35. And therapy access of the patient, that is those patients who has the criteria, that is the class 1 criteria for having this treatment, only 80% of the patient, nearly 80% of the patient in the developed countries in Europe and America can get the scope to have this therapy. It is nearly 10% in case of the India, but the number of is still, it is very much difficult to calculate as because it is actually uncertain in Bangladesh, that is less than, a fraction of less than 1. So this is the CRT access and implantation rate in Bangladesh. Also in case of the ICD therapy, we can see this is the 2013 data and collected from the white book of the Asia Pacific Heart Rhythm Society. You can see this is the number of the ICD implantation in New Zealand, Singapore, Korea. In all the cases, even in the 2080, the number of the ICD implantation in that is the New Zealand was 124. In Singapore was 553. And even in India, it was the significantly, that is the Malaysia, Thailand, and India, it is more than, that is the 1.5. But in case of Bangladesh, it is less than 1, that is nearly less than even 0.5. So the implantation rate of the ICD therapy, that is the New Zealand 124 per million, Japan 50, India 15, and the Bangladesh is 0.54. So this is the situation of the implantation rate and access of the devices in Bangladesh. This is the situation. We have got the expertise, but this is a factor. And what is the challenge actually? Why it happened? As because in case of the drugs, we are using this, but still the introduction of that the AC repeater RNA is still underused, and the adherence of the physician to the guideline is less than expected. And many of our patients has got the comorbidities like CKD, CLD, and COPD. And atrial fibrillation and hyperkalemia are common in the natural course of this heart failure patient. So these are the some problem or challenges for the management of the heart failure in Bangladesh for the drugs, and for the devices. We face these challenges, particularly the finance, awareness, adherence to the guidelines, and the number of the skilled operators in the countries. So for the device management, these are the problems we face in Bangladesh, but we have to still overcome. And these are the areas we need to develop in Bangladesh, particularly practice of the guidelines for the evidence-based medicine and care delivery. We need the heart failure team. And for the education, we need the education of both the patients and the nurse. And for the prevention, we have to encourage both the primary and secondary prevention of the heart failure. So these are the areas we need to develop in Bangladesh. And we are here. Now we are here and we have to go there. So this is the long way we have to travel. So this is the situation in Bangladesh. We are here and we have a target, we have a dream to go there. So we have to long distance we have to cover and we have to long problems we have to face. So this is the situation in Bangladesh. And thanks everybody for their patient sharing. Thank you very much.
Thank you, Professor Atahar, for your nice talk on the drug and device therapy in Bangladesh from beginning till now. And you have nicely described the obstacles or the limitations of the therapy in our Bangladesh, in the context of Bangladesh. Now, I will request discussants, chairpersons to have any comments or any questions regarding the presentation and the topics that has been delivered.
I have one question to Professor Atahar, sir.
Welcome, Ashok.
So what do you think about why so much less penetration of the device in our population? One factor is economy. I think that economy is not always a factor because so much money the common people are utilizing for stenting and CABG. When they are asked for CRT or ICD, they are very much reluctant. And whenever they used to go to other cardiologists or medicine specialists, they usually got inhibited by them. Many of the cases I have seen that there is a belief that this is not so much effective therapy. So what is your message to the medicine specialist or the cardiologist, those who are not actually so much interested in this device therapy?
So thank you, Ashok, for your nice question. And I think that this is the question for everybody, because actually it is the practice of the guidelines. I think the practice of the guidelines can solve all the problems, because if we follow the guidelines, we have to refer the patient in the appropriate location. We have to recommend. So if a patient has got the ejection fraction less than 30, patient has got the syncope, sustained VT, but we are not recommending the ICD or like this. So we have to follow the guidelines. I think it is the practice of the guidelines, and awareness of the physicians are more important than the awareness of the patient. So I think it is the awareness of the physician and it is the practice of the guidelines that can solve the problems.
Thank you, sir. Okay. The same thing happened when initially we started angiogram in 2000 or around 2000. Most of the people, most of the physicians, they are very much reluctant to send the patient for angiogram. Now the situation is different. The patient themselves comes to us.
But here the situation is somewhat reverse, as because
I have some observation.
Yes, sir.
In this regards, regarding electrophysiology of Bangladesh, we have two renowned electrophysiologists. One is Mr. Atahar, another is Mohsin. Problem is that what I mean, this is people's awareness, and most of the institute and medical college of Bangladesh, even they do not so much aware regarding this best treatment in Bangladesh. I think it is one of the best regarding people. If we motivate the people, we actually indicate patient, so many patients in our country. So when patient, after so many doctors for medical college, they have in district level hospital, and last up to me, then I tell the patient, please go to Professor Atahar for your proper treatment. I think we should make the awareness of the patient that this type of treatment is the best option. It is going on in our country.
Dr. Ashok, I want to add that awareness should start from myself, should start from cardiologists. Our young cardiologists or non-invasive cardiologists, they are not aware. How medicine specialists will be aware?
Yes,
so
yes.
we should be aware first, then entire medical community, then printing media, electric media, to know that these are the therapies, these are the treatments available in country, then political leaders, involvement of the political leaders, only then it will be very much available and patient will be benefited.
I have got a comment. I have got a comment for you, sir. Atahar, sir, do you think making improving the number of skilled manpower, the persons who can implement ICD and CRT will increase the number of cases?
Yes, I think this is one of the options. That is if the operators, as because operators is also one of the factor, but I think first of all, it is the practice of the guidelines. Unless we practice the guidelines, this problem cannot be solved. There are the many, a patient actually give consultation with the many of the doctors. You see, none of the doctors actually recommend that you need this kind of the therapy.
Yes.
So this is the common situation. Yes, if the number of the operators are increased, definitely the problem, that is the number of the procedure will be increased. But I think that first of all, as because you see, over the periods of 12 years, starting from 2008, over the last 12 years, the number of ICD and CRT implementation rate is around 50 per year. There is no change. There is no change.
Another, if Atahar does not mind, my observation is another observation in this aspect. There are some manpower in this country and dedicated remain acting in so many hospitals, and they got trained in this subject, but after getting the training from outside, they are not practicing in our country. This is a great problem, I think. This is also a problem in our country.
No, this is not the sir. This is not the problem. Not also in not only in our country. I have seen in India, many of the juniors, they used to practice or they used to train up with EPS and device, and subsequently they have switched over to the coronaries. I have seen many of my juniors, many of my friends. So possibly that is the different issue regarding the monetary factor is one of the important.
In this connection, may I request Chaudhary Hafizul Hassan,
yes, sir,
from USA, he used to come to Bangladesh on and off. Please give you a comment about the perspective of the Bangladesh regarding the device therapy in Bangladesh. Why there are so much.
So my question is that, you know, we are too much into coronaries, and there are many reasons for that. But do we have any established heart failure clinics? Because I tell you that even in our practice with about 25 cardiologists, we often see that the heart failure care is not optimal until we send the patient to the established heart failure clinic. In the heart, it is a comprehensive approach, and in heart failure clinic, often you get that, and also it helps in terms of, you know, we can quote papers after papers that established heart failure clinics, the reduction in hospitalization, and getting the guidelines directed therapy, all this. And we have like nurse practitioners also who help the heart failure clinic. And you can get device therapy monitoring, you know, you talk about cardiomim. So I think maybe it is time that we dedicate our resources for training heart failure specialists and also establish heart failure clinics to address these issues. Probably starting from the institution. I think that's probably better.
May I add something?
Question.
Next.
Dr. Abdullah Jamil, who is also an electrophysiologist, please give your comment in a very
I just want to add to Chaudhary Hafiz Bhai. I want to add to Chaudhary Hafiz Bhai that heart failure clinic is difficult to establish in our country. Mostly as because no physician nor cardiologist want to lose their patient. They are afraid of if they send the patient to the heart failure clinic, they are not going to get back the patient. So no one is going to send the patient to me to follow up after putting a device or something like that, or a patient diagnosed as heart failure. That's the main hindrance for establishing a heart failure clinic in Bangladesh. Thank you.
Thank you, Jamil Bhai, but this obstacle can be easily overcome.
No, that can become
May I add something?
when there will be
let
me finish. When there will be group practices
and
in
without
USA.
policy, we can overcome the problem.
May I add something?
No. Time.
You can
Later on.
Can I add something?
I think we are running out of time. We can
yes,
discuss it later. I think we can move on to our next lecture. This is by Professor M.G. Azam. Professor M.G. Azam, are you ready? You can go for your lecture.
Okay, let's. Can I?
Professor M.G. Azam will be talking on heart failure with reduced ejection fraction. What to do when heart and kidney are no more friends. So you will be talking on a conflict zone where heart and kidney are no more friends. Dr. M.G. Azam is a professor of cardiology working in National Institute of Cardiovascular Disease. He is also the scientific secretary of BSCI. And Professor M.G. Azam, it's your time.
Thank you, Mahmudullah Firuz, for your kind comments. Actually, we are running of time. That's why I just go for fast, because most of the topics covered by my previous speaker very nicely and elegantly, and the very few point I can address to you. If left remain, then my next speaker will cover it. So let's see my talk when heart and kidney are no more friends. This is my disclosures, and if you see the left panel, heart failure continues to be a global disease by prevalence, affecting almost around 25% of adult populations. Similarly, chronic kidney disease is also a global epidemic with increasing prevalence, affecting almost around 16% of adult population. The incidence of both conditions didn't decline in past decades, rather increasing day by day. The coexistence of heart failure and chronic kidney disease will increase challenge regarding various diagnostic and therapeutic measures, which is nicely described by Ramon Gonzalez, and which accelerates our complications and increase the risk of death. And I think everyone we know Professor Guyton, who is one of the great cardiovascular physiologists of 20th century, who was famous for outstanding contribution to the crosstalk theory between the heart and kidneys. And he nicely said, when one organ becomes dysfunctional, the other may well be affected as well. So when heart and kidney are no more friends, then there is a lot of problem is there, and there is some crosstalk. If fail to crosstalk between the crosstalk, if you look at the crosstalk theory between heart and kidney, then various pathophysiological changes occurs. As we know, many patients with heart failure have underlying chronic kidney disease, and patients with chronic kidney disease are very much prone to develop cardiac failure. However, 55% of heart failure patients have eGFR less than 60 ml per minute. Most of the patients remain asymptomatic, and some patients may be symptomatic. Very rarely, some patient end-stage renal failure and end-stage heart failure may very vigorously symptomatic, and that is around 10% of cases that make us very difficult in a situation to tackle them. And 40% of patients with chronic kidney disease have heart failure. In our clinical practice, what we face, 50% of acute heart failure patients have worsening renal failure. That gives us a big challenge. If you go for the short review, staging of chronic kidney disease, stage 1, stage 2, stage 3, and stage 4, stage 5, mild to moderate to severe. But right now, we are treating up to stage 2 very nicely. Some extent we go for treat the patient stage 3, okay, but stage 4 and stage 5, it is very difficult situations. If you look at this, this is not newer classification as Gonzalez showed you. Hopefully in August we will get the newer terminology heart failure. But now today we are here to concern our is reduced heart failure patient with advanced chronic kidney disease. If you see whenever the patient are advanced heart failure situation, they are really worsening situation in case of chronic kidney disease. Now I show you one case scenario, 56 years of male with reduced ejection fraction around EF 35%. He's diabetic, hemoglobin A1C around 7.5% with chronic kidney disease. EFR was 29 ml per minute and status post he had a history of ICD implantation 6 years back. Dear friends, this is the most important things. Should we continue previous heart failure medication, mostly triple therapy, as showed by Professor Atahar and Gonzalez very nicely? Whether, do you know, we have some recent upcoming data and with newer drugs, either we change heart failure disease modifying therapy. Due to time constraint, so I just skipped some slides because, I have to cover the time. If you look at the treatment of heart failure with chronic kidney disease, there are many landmark clinical guidelines for managing heart failure patient as well as chronic kidney disease individually. But the hard reality is that there is no agreed or universal guideline for managing heart failure patient with chronic kidney disease. Though there is a continuous improvement in treatment of heart failure all over the world, when the heart failure is combined with chronic kidney disease, the effective therapies are dramatically underused. But very interesting things, one group, especially New York-based Kidney Foundation Group, Chronic Kidney Disease Outcome Quality Initiative, interestingly, when they offer the level of care of heart failure, they offered the level of care of heart failure offered to people with chronic kidney disease should be same as is offered to those without chronic kidney disease. But, in our clinical practice, we are really some extent shaky to treat our advanced chronic kidney disease case, especially when creatinine rise 3 or 4 or 5 milligram per DL or EGFR less than 30 or 34, like that. If you see the clinical trials in heart failure and chronic kidney disease, most of the chronic kidney disease evidence, we have up to stage 3 strong evidence, weak, moderate and strong evidence, but in stage 4 and 5, we don't have enough strong evidence. This is the scenario of chronic kidney disease in stage 3. As you can see here, most of the clinical trials include patient in class 3 chronic kidney disease. But most of the information that we have about disease modifying therapy in this population from subgroup analysis of big heart failure trial. I'm showing you some just big heart failure trials. This, you can see the slide. This is this meta-analysis is from beta blocker collaborative group. The effect of beta blocker effect is actually up to EGFR 30, that is neutral. So you can use stage 3 beta blocker without any hesitancy. When you consider stage 4, then you can some extent need for further disease modification with weak evidence. And if you look at this slide, let me show you the evidence what we have for AC inhibitor. This is the data from SOLVE trial. Here you can see the enalapril, the effect of mortality of this patient with CKD was non-significant if you compared with those patients with chronic kidney disease, without chronic kidney disease. But interesting thing is that AC inhibitor improve quality of life and reduce recurrence of hospital admission. So you can use up to stage 3 very confidently. And if some extent stage 4, you have to need further dose modifications. On the other hand, if you look at the CHARM trial, this is the evidence of CHARM trial with candesartan. As you can see, the benefit of candesartan was not related with the presence or absence of chronic kidney disease. The paradigm trial also have a very interesting subgroup analysis of patient with or without chronic kidney disease. And you can see here the benefit of sacubitril valsartan was independent of the presence of chronic kidney disease. Although in the population of sacubitril valsartan, it was observed an increased urinary albumin creatinine ratio. But these changes are not related to increased mortality. You can see here the MRAs are the disease modifying therapies nicely demonstrated by Gonzalez and are very important in patient with reduced ejection fraction heart failure patient. There is a lot of concern about their use in patient with chronic kidney disease because most of the trial exclude patient with chronic kidney disease stage 4 excluded. I think one of our participant asked a question when we should stop spironolactone. I will give the answer later on. And this is the trial from RAILS trial where you can see the benefit of spironolactone was independent of the presence of chronic kidney disease, but the population prevents and presents more often hyperkalemia with or without concomitant drug used like AC inhibitor, ARB or ARNI. So friends, we need monitoring of this effect in this population. I hope and we believe potassium binder will be the future direction to treat those group of patients. And if you look, finally, this is the data from trial this is the data from trial of SGLT2 inhibitor that is also nicely showed by Dr. Gonzalez. This is medication that have wonderful neuroprotective effect. So you can see here the death from reduced trial, Emperor reduced trial. Remember that the Emperor reduced trial include patient with eGFR more than 20 ml per minute. And here you can see less declining GFR in comparison to placebo. You see, in comparison to placebo. And that is, and also DAFA heart failure trial, it was proves that the beneficial effect of dapagliflozin was independent of GFR of the patient. So we can use, it is also in advanced chronic kidney disease conditions. If you look, yes. So now let's move to our case scenario. What we know about the data CKD in stage 4, as because you see, we don't have enough data. As you can see here, we have lack of strong evidence of how to treat those patients. Most of the things are we know from registry data and also cohort studies. So you see, but I have to tell you about Victoria trial, which also showed nicely by Gonzalez and which published last year and shows new evidence about how to treat those patients. Because in the Victoria trial that include patients with recent episodes of worsening heart failure patients, 15 of that population have chronic kidney disease with stage 4. You surprisingly, you can understand the effect of varicose disease here is consistent with or without chronic kidney disease. So this is the very interesting evidence, because I told you earlier before, we don't have enough strong evidence what we should do in these categories of patient. And I'm very much close to my slide, and this is the very important slide, how dose adjustment of patient with reduced ejection fraction heart failure patient with chronic kidney disease. If you see, as I told you and showed you some subgroup analysis of big trial, MRA should be contraindicated in stage 4, as our case is stage 4. So we shouldn't consider MRA, but we can consider ACE inhibitor or ARB or ARNI. But my preference, we should start ARNI. How should I start ARNI? Low dose of ARNI we should start. Then we can escalate the dose as much as possible, 2 to 4 weeks interval by periodic follow-up. And if you consider beta blocker, no need of dose adjustment. On if you use bisoprolol, that time you should consider dose reduction. Otherwise, carvedilol and metoprolol succinate, no need to dose reduction. If you consider ACE inhibitor, most of the ACE inhibitor, when you try to institute, then you can consider half dose initially, but perindopril is not recommended. But in our Bangladesh, we are mostly used ramipril, ramipril. So in this ramipril, we should start 1/4 of dose initially, then we can escalate the drugs. Regarding ARB, no dose adjustment, but don't consider it is fast. First, you should try to ACE inhibitor or ARNI as you like, but you have to remember, we should follow the patient with blood pressure, serum potassium, kidney function. If the patient have diabetes, as you should follow up also blood sugar level or hemoglobin A1C level. Now, I'm telling you, that is also important slide. When you institute any ACE inhibitor, ARNI or ARB, there are some extents. Initially, some kidney function sometimes deteriorated. Nothing to be worried. You just follow up very critically, try to see whether the creatinine level increase less than 30%. You should continue the drugs as before, until and unless symptomatic hypertension is developed. But you should be careful when 30 to 50% of raised creatinine level, then you should consider dose reduction and temporary withdrawal, and you can follow up critically. If more than 50%, you should stop, or eGFR less than 20, or irrespective of eGFR, if you have uremic symptoms, you should stop the drugs. So ladies and gentlemen, and dear my friends, you see the chronic kidney disease and advanced heart failure, coexistence of heart failure and chronic kidney disease around very advanced stage, 10% case. That is our big problem in our clinical practice, and this worst combination leading to worse prognosis. So in my take-home message, care should be personalized for heart failure patient with reduced ejection fraction with advanced chronic kidney disease. Though we have limited evidence, but we should remember those response uncertain for the benefits. But it is very important to close monitoring of blood pressure, heart rate, GFR, potassium is very important. And finally, very Varicose can be a safer option for the patient with heart failure with chronic kidney disease. Sorry. And I believe everybody, you know, the good physician treat the disease, the great physician treat the patient who has the disease. And as you know, from the Gonzalez lecture, he told hopefully we will get final recommendation from AC in August. So hope the future is bright, and one day our corona pandemic is over and we will again meet in person. Thank you very much.